I want you to picture a scenario for a second. Something that plays out in surgical wards all over the world pretty much every single day. So you have two patients, and they both undergo the exact same major surgery.
Right.
I mean, we are talking about the identical procedure here. Let's say it's a really complex bowel resection. It's done on the exact same day, in the exact same hospital, and by the exact same incredibly skilled surgeon.
So all the variables are controlled.
Exactly.
Yeah.
The surgical variables are as perfectly controlled as humanly possible. But the clinical outcomes, they diverge completely.
Yeah, they go in totally different directions.
Right. So one patient is extubated quickly. They start walking the halls maybe a couple of days later, and eventually they just walk out the front doors on a clear trajectory to a full recovery.
And the other patient?
The other patient takes a complete nosedive. They develop these severe systemic infections. Their surgical wounds suffer from dehiscence, which, I mean, the fascia literally just gives way. They end up intubated again, they're trapped in the intensive care unit, and they just start cascading right into multi-organ failure.
It is a profound and honestly terrifying contrast. And, the natural instinct for most people, even seasoned clinicians sometimes, is to look for some kind of mechanical failure when a case deteriorates that rapidly.
Like maybe the stitches failed or something.
Exactly. We immediately want to look at the operative report to see if there was an anastomotic tension issue. Or we just assume the underlying pathology, maybe the malignancy they were operating on, was just overwhelmingly aggressive.
Right, we blame the disease or the tools.
Yeah. But when you dive deep into the clinical data we're unpacking today, you realize those assumptions completely miss the silent variable running in the background.
And that silent variable is nutrition. The difference between those two patients wasn't about the precision of the scalpel or the quality of the sutures. It was entirely about the metabolic reserves they brought with them to the operating table.
Which brings us right to the core of what we're doing today.
Yes, exactly. That is the mission of our deep dive today. We are taking a comprehensive, totally unvarnished look at the hidden, life-saving science of surgical nutrition. And for you listening, this is going to fundamentally shift how you understand healing, recovery, and really just the sheer brutal resilience of the human body under stress.
Because surgical nutrition rarely gets the spotlight. I mean, the drama of medicine is almost always focused on the operating room, right? The bright lights, the bypass machines, the robotic arm.
It's what you see on TV.
Exactly. But the reality is that the surgery itself is just an orchestrated trauma. The actual survival, the real physiological heavy lifting, that happens in the days and weeks afterward.
So how are we defining surgical nutrition for this deep dive? Because we aren't just talking about hospital cafeteria food here.
No, not at all. We are defining it today not as some casual diet plan or, a tray of Jell-O, but as the rigorous science of preventing the human body from literally consuming itself during periods of extreme physiological stress.
Preventing the body from eating itself. That is that's a visceral, almost disturbing image.
It is. But it perfectly frames the stakes we're dealing with.
There is a specific clinical maxim from our sources that really anchors this whole concept. It says, "The surgeon cuts once. Starvation cuts every day."
Oh, that's a powerful quote.
When you think about the patient just lying there in the recovery room, the implications of that are staggering.
Well, think about it like this. The physical trauma of the surgery has a definitive beginning and end. The surgeon makes the incision, they perform the intervention, and they close. Done.
Right.
But if that patient is fundamentally malnourished, the physiological damage doesn't just magically stop when the anesthesia wears off. Starvation is this ongoing, relentless assault at the cellular level.
Because the body still needs materials to heal.
Exactly. If the body doesn't have the circulating amino acids and micronutrients it needs, it has absolutely no choice but to start harvesting them from its own tissues.
So it starts breaking itself down.
Skeletal muscle just disappears. Immune cells lack the substrates to proliferate. And the fibroblasts, the cells that build tissue, they simply cannot synthesize the collagen needed to knit that surgical wound back together. So the mechanical intervention might have been flawless, but the metabolic environment just sabotages the entire process.
Which really challenges the inherent bias in how we evaluate health in the first place. I mean, we have this concept in the sources of the bankrupt patient, and it forces a complete recalibration of what a sick person actually looks like.
It really does. Because if you hear the word malnourished, you probably picture a profound emaciation, right?
Yeah, I picture someone who is visibly cachectic, severe muscle wasting skin and bones.
Most people do. But clinical malnutrition is so often a silent killer. You can easily have a patient who walks into the pre-op clinic looking completely normal. They have a normal BMI, they speak clearly, they carry themselves well, but at a cellular metabolic level, their reserves are entirely bankrupt.
And that's one of the most dangerous psychological traps in medicine, isn't it?
Absolutely. We subconsciously judge physiological readiness by outward anthropometric appearances, how they look on the outside, but surgical readiness is dictated entirely by metabolic reserves on the inside.
So let's look at some of the chronic realities of the patients who actually end up on the operating table, because it's not always obvious. Take oncology patients, for instance.
Cancer patients are a perfect example. Tumor metabolism drastically alters systemic inflammatory pathways. You have these cytokines like TNF-alpha and interleukin-6 that are driving profound metabolic changes, causing the body to break down muscle even if the patient is still eating.
But often they aren't even eating, right?
Exactly. They are avoiding food because a gastric tumor causes early satiety. They feel full after 2 bites. Or maybe a pancreatic mass causes agonizing visceral pain every time they try to digest something. Visually, to the surgeon or the family, the patient might just look like they've lost a few pounds, but their intracellular protein reserves are completely tapped out.
Wow. Or consider the elderly population facing, say, orthopedic or abdominal surgery.
Right, there is a baseline sarcopenia there, just age-related muscle loss.
But paired with that, their natural thirst and hunger drives often just wane as they get older. They might be eating a piece of toast for breakfast, maybe half a sandwich for dinner, and sure, that sustains a sedentary lifestyle.
But it provides absolutely nothing in the bank for the massive hypermetabolic demand of impending surgery.
And then you have chronic alcoholics. This one really surprised me. They might be taking in 3,000 or 4,000 calories a day, so they maintain their weight, or they might even present as obese.
But those are entirely empty calories. They're derived from ethanol, which actively suppresses hepatic gluconeogenesis and offers absolutely zero essential amino acids. It's the ultimate illusion of health.
The illusion of health. That's a great way to put it.
And you see it acutely in patients with gastrointestinal obstructions, too.
Like a bowel obstruction.
Yeah. A patient with a bowel obstruction might be third spacing massive amounts of fluid right into their gut. They're vomiting anything they try to swallow, and they're suffering severe electrolyte derangements. They arrive at the hospital acutely depleted.
So the clinical reality across all these totally different scenarios is that malnutrition is wildly common in the preoperative population.
It is severely underdiagnosed because we rely way too heavily on the eyeball test.
And it is absolutely deadly. The patient walks confidently into the pre-op holding area, but they have absolutely zero biological currency to fund the massive physiological cost of what is about to happen to them.
Euro currency, that's exactly it.
To really drive home what that internal bankruptcy means for you listening, let's look at a structural analogy from the sources. Think of a patient undergoing major surgery as a building undergoing a massive structural renovation.
Okay, so like this.
The surgery itself is the demolition and the reconstruction. In this environment, protein is the cement.
It's not just a dietary preference. It is the fundamental structural requirement.
Without the cement, the caliber of the architect or the builder is totally irrelevant.
Right. You can have the most brilliant, technically gifted surgeon meticulously aligning the tissues, but if the physiological cement is missing, the structure will fail. In the body, when that protein cement is weak or absent, the walls crack, the roof leaks, and the foundation collapses.
Let's actually translate those structural failures into real surgical complications. So the cracked walls, those are the surgical incisions.
Exactly. Without adequate protein synthesis, specifically the cross-linking of collagen, that wound has zero tensile strength. The fascia, which is the really tough connective tissue holding the abdominal wall together, it just pulls apart under the normal tension of breathing or coughing.
Just from a cough.
Yes. That is what we call wound dehiscence.
And the leaking roof in our analogy is perhaps the surgeon's greatest fear, anastomotic failure.
An absolute nightmare. When a surgeon resects a diseased portion of the colon in staples or sews the two healthy ends back together, that connection is the anastomosis. They are relying entirely on the patient's body to seal that connection over the next few days.
The surgeon brings the ends together, but the body has to actually fuse them.
Precisely. If the patient is protein depleted, the tissue lacks the raw materials to proliferate and seal the microscopic gaps. The connection breaks down.
And then what happens?
Highly infectious enteric contents stool basically leak directly into the sterile peritoneal cavity.
Oh, wow.
And that leads directly to the collapsing foundation of our analogy, which is the onset of profound sepsis, systemic inflammatory response syndrome, and a catastrophic cascade right toward multi-organ failure. The entire integrity of the surgical intervention hinges on the availability of that protein cement.
Which brings us to our first fundamental takeaway for the deep dive. No protein, no progress.
You cannot cheat the biological math.
You cannot heal a macroscopic surgical wound without the microscopic building blocks. And understanding that non-negotiable requirement is critical when we look at the timeline of what actually happens the moment the anesthesia is reversed.
Because the body doesn't just quietly rest and begin a peaceful healing process.
No, it goes into a state of highly orchestrated, absolute panic.
The clinical term for this panic is the catabolic storm. It is a massive neuroendocrine and inflammatory cascade.
Why does it panic, though? The surgery is meant to help.
We have to remember that the brain and the central nervous system cannot differentiate between a life-saving surgical incision and a life-threatening physical attack.
Oh, so it just feels the cut.
Right. To the hypothalamus, a massive tissue disruption is a survival threat. A scalpel feels exactly like a bear attack. The body's response is evolutionarily hardwired and generally unfolds in two very distinct sequential phases. The first is the ebb phase.
EBB, the ebb phase.
Yes, and that dominates the immediate 24 to 48 hours post-trauma.
During this ebb phase, the physiological mandate is essentially just save energy. It's a state of profound shock and preservation.
It is an acute triage mechanism. In the ebb phase, you see a drop in the basal metabolic rate. Cardiac output often falls, core body temperature drops, and tissue perfusion is significantly reduced.
Clinically, what does that patient look like?
You'll see a patient who feels cold to the touch, they look pale, and they're highly lethargic. The body is essentially freezing its resources, minimizing energy expenditure.
Why freeze everything, though?
Because it is trying to assess the extent of the damage, stabilize blood volume, and ensure that the most vital organs, the brain and the heart, survive the initial insult. It is a state of physiological hibernation, and it's driven by a massive surge in catecholamines like epinephrine and norepinephrine that clamp down peripheral blood vessels.
But that hibernation is temporary. Once the immediate hemodynamic shock is stabilized, the body violently pivots into the second stage, which is the flow phase.
The flow phase.
If the ebb phase was about minimizing output, the flow phase is screaming, burn everything!
It really is. The transition into the flow phase is marked by a hyperdynamic state. The metabolism just absolutely skyrockets. Cardiac output increases, oxygen consumption surges, core temperature rises.
The patient gets a fever.
Often, yes. The body enters a state of severe catabolism, which is the breakdown of complex molecules into their simpler parts. Severe trauma, major burns, massive surgical interventions, they all act like a metabolic fire.
So what's happening internally during that fire?
The liver drastically alters its protein synthesis. It shifts away from making normal proteins like albumin and instead mass produces acute phase reactants like C-reactive protein to manage the systemic inflammation.
And the fuel for that metabolic fire has to come from somewhere, right?
Yes.
Since the patient isn't sitting up eating a steak dinner while lying in the ICU, the body ruthlessly cannibalizes its own skeletal muscle.
It has to. It harvests the amino acids required to synthesize those inflammatory proteins and to fuel the immune system.
Which fundamentally redefines the clinical approach to feeding during this period. The goal of early nutritional support isn't just to provide a comforting meal so they don't feel hungry.
Not at all. The clinical objective is to provide exogenous substrates outside fuel to support recovery without fueling that metabolic fire.
Without throwing gasoline on it.
Exactly. You are trying to hand the body the raw materials it is desperately demanding so it doesn't have to tear down the house to keep the furnace burning.
Let's really drill down into the mathematics of that cannibalization because the numbers here are terrifying. There is a widely used clinical concept known as nitrogen balance, and it functions exactly like a physiological bank account.
It's a perfect analogy.
Nitrogen is the unique elemental marker of amino acids. It's what separates proteins from carbohydrates and fats.
Right. Carbohydrates and lipids are composed of carbon, hydrogen, and oxygen. Proteins have those too, but they also contain nitrogen.
And the body doesn't store excess protein, right? Not the way it stores fat in adipose tissue or glucose as glycogen in the liver.
Correct. Any nitrogen entering the body must be used for structural synthesis, or it gets stripped off the amino acid in the liver, a process called deamination. It's then converted into urea and excreted by the kidneys in the urine.
So, by measuring the nitrogen going in through feeding and subtracting the nitrogen coming out in the urine, clinicians can see the exact state of the patient's muscle bank account.
Exactly. A positive nitrogen balance means more is coming in than going out. The body is anabolic, building or maintaining tissue. A negative nitrogen balance means the body is catabolic, overdrawing the account and actively destroying muscle mass.
And the conversion rates are what really blew my mind. The biological math dictates that roughly 100 grams of dietary protein yields about 16 grams of nitrogen.
So protein is roughly 16% nitrogen by weight.
Yeah.
But the truly critical multiplier is on the loss side.
This is the scary part.
For every single gram of nitrogen lost in the urine beyond what is taken in, the patient is losing approximately 30 grams of lean, wet muscle tissue.
1 gram of invisible nitrogen in the Foley catheter equals 30 grams of functional skeletal muscle stripped from the patient's body.
Let's look at a realistic ICU scenario to put that in perspective. You have a patient recovering from a major abdominal catastrophe. Because of the hypermetabolism.The phase we just talked about, they are excreting massive amounts of urea. Let's say their nitrogen balance calculates to a negative 10 grams a day.
Okay, negative 10.
10 grams of nitrogen loss multiplied by 30 means that patient is metabolizing 300 grams of their own muscle tissue every single 24 hours.
For you listening, 300 grams is roughly 2/3 of a pound of muscle, just vanishing day after day.
And the crucial realization here is that this isn't selectively targeting the biceps or the calves. The body doesn't care about aesthetics. It is indiscriminately breaking down skeletal muscle everywhere.
Which includes the diaphragm, right? The primary muscle of respiration.
Yes, and it includes the intercostal muscles between the ribs.
So when you see a patient failing to wean off a mechanical ventilator on, say, post-op day 7,
It is frequently because their diaphragm has literally been catabolized to the point of structural failure. They physically lack the muscle fibers to generate the negative intrathoracic pressure needed to pull air into their own lungs.
it's not that their lungs are broken, it's that the engine pulling the air is gone.
The daily theft of muscle explains the profound weakness of the bedridden post-op patient. Their functional strength has been sacrificed to fuel the acute phase response of their own recovery.
So protein is clearly the heavy lifter, the macrostructural cement. But the metabolic machinery also relies on a vast network of micronutrients.
The vitamins and minerals.
Right. And there is a phrase in the research that perfectly captures the danger of ignoring these smaller players. Vitamin deficiencies don't shout, they whisper, and surgeons pay the price.
It is a brilliant way to frame the insidious nature of micronutrient depletion. If a patient is burning through half a pound of muscle a day, the clinical signs become obvious very quickly. They look wasted.
But a vitamin or mineral deficiency doesn't present with dramatic early warning signs?
No, it operates totally under the radar. It disrupts highly specific enzymatic pathways until a catastrophic system-wide failure completely unravels an otherwise perfect surgery.
Let's systematically walk through some of the critical culprits here, starting with vitamin C. Because outside of a hospital, people think of vitamin C as, a gummy bear you take during flu season.
Orange juice.
Right. But in the surgical ward, ascorbic acid has a completely different structurally vital role.
Vitamin C is an essential cofactor for two enzymes, toluene hydroxylase and lysyl hydroxylase.
Okay, and what do those do?
These enzymes are responsible for the hydroxylation of proline and lysine amino acids within the collagen matrix.
So they modify the collagen.
Exactly.
Okay.
Without this specific chemical modification, the collagen fibers cannot cross-link. And without cross-linking, the collagen remains this weak, disorganized gel rather than a tough structural scaffold.
So if a patient has a whispering vitamin C deficiency,
Then fibroblast activity is fundamentally useless. The surgeon can place perfect retention sutures, but the biological tissue will simply fail to bind together. That leads directly to the dehiscence we discussed earlier.
it essentially turns off the body's ability to manufacture structural glue.
That's wild. What about vitamin B12? The sources link this deficiency very specifically to the anatomy of the gastrointestinal tract, particularly patients who have undergone an ilealresection.
This is a fascinating mechanism. The absorption of vitamin B12 is an incredibly highly specialized process. It isn't just passively absorbed anywhere in the gut like water. Right.
When B12 enters the stomach, it binds to a protein called intrinsic factor, which is secreted by the gastric parietal cells. This B12 intrinsic factor complex travels all the way through the small intestine until it reaches the terminal ileum.
Which is the very last segment of the small bowel before the colon.
Right. The terminal ileum has specific receptors designed exclusively to absorb this complex. If a surgeon has to resect the terminal ileum, Maybe due to Crohn's disease or ischemia or a malignancy, the patient permanently loses the physical hardware required to absorb vitamin B12.
And because the liver stores a massive reserve of B12, this deficiency truly whispers for months or even years before it presents clinically.
Yes, it can take years. But when the hepatic stores finally run out, the consequences are severe. B12 is vital for DNA synthesis, particularly in rapidly dividing cells like red blood cell precursors in the bone marrow.
So they stop making red blood cells properly.
The deficiency manifests as megaloblastic anemia. The bone marrow produces these large, dysfunctional red blood cells that cannot efficiently carry oxygen. The patient becomes profoundly hypoxic at the tissue level.
Not because of a lung issue or bleeding out, but because the microscopic oxygen delivery vehicles are fundamentally defective.
Exactly.
Then we have vitamin K, which is directly tied to hepatobiliary function and the coagulation cascade.
Vitamin K is a fat-soluble vitamin. To absorb anything fat-soluble from the diet, the gut requires bile salts, which act as detergents to emulsify the fat into my cells.
So what happens if there's a blockage?
If a patient has a biliary obstruction, let's say a tumor in the head of the pancreas, compressing the common bile duct, or a severe gallstone impaction, bile cannot flow into the duodenum. Consequently, vitamin K passes straight through the GI tract, completely unabsorbed.
And the liver requires vitamin K as a cofactor to synthesize several critical clotting factors, right? Specifically factors 2A, I, IX, and X.
Yes. The enzyme gamma-glutamyl carboxylase requires vitamin K to activate those factors. Without it, the clotting cascade is completely paralyzed.
And again, this whispers quietly while the patient is walking around beforehand.
Right, but the moment the surgeon makes the primary incision, they are faced with an absolute nightmare. The patient develops a severe coagulopathy. They simply will not stop bleeding. They're oozing from every capillary bed because the biochemical switch for coagulation is turned off.
The dependencies are just incredibly fragile. And it's not just the vitamins. We also have to look at the trace elements. They are called trace because they exist in minute quantities, but their systemic roles are foundational. Things like zinc, iron, and magnesium.
Let's start with zinc. Zinc is heavily involved in cellular proliferation and is a critical component of matrix metalloproteinases, which remodel tissue during wound healing.
It also helps the immune system, doesn't it?
Massively. It is essential for the proliferation of T cells and B cells. A zinc deficiency severely blunts the immune response, leaving the patient highly vulnerable to nosocomial or hospital-acquired infections.
And iron.
Iron, similar to the B12 pathway, is the central atom in the heme molecule. It physically binds the oxygen. Without iron, you simply cannot sustain the massive oxygen debt required by healing tissues.
And finally, magnesium, which has profound implications for cardiac electrophysiology.
Magnesium is a required cofactor for ATP binding and is critical for the function of the sodium-potassium ATPase pump. That pump maintains the electrical resting potential of every cell in the body, most notably myocardial cells, heart cells.
So a lack of magnesium messes up the heart's rhythm.
Hypomagnesemia leads to a prolonged QT interval on the EKG, and it can precipitate sudden lethal arrhythmias like Tourvide's de Pointes.
So the overarching insight here is that you absolutely cannot ignore the micronutrients. You can provide thousands of calories and hundreds of grams of protein, but without the microscopic cofactors to facilitate the chemical reactions, the macroscopic recovery simply halts.
The machine needs oil, not just gas.
Perfect analogy. Now, I want to pivot to a physiological state that generates a lot of confusion, especially with the explosion of intermittent fasting in popular culture right now.
Oh yes, the fasting trend.
We hear constantly about how fasting promotes autophagy, it clears brain fog, it improves insulin sensitivity. But there is a massive physiological chasm between a healthy person skipping breakfast and a surgical patient who is fasted and stressed.
It's completely different.
We really need to shatter the myth of safe fasting in the perioperative environment.
It is a critical distinction to make. A healthy person undergoing a voluntary 16-hour fast is in a neurohormonally calm state. Their body smoothly transitions from burning dietary glucose to tapping into hepatic glycogen and eventually mobilizing free fatty acids from adipose tissue. It is an organized, low-stress metabolic shift.
But when you introduce the profound physiological stress of a major illness, trauma, or surgery,
The rules of starvation change entirely.
let's track the exact timeline of starvation under stress. It begins with the short-term phase. The body's immediate backup generator is glycogen, those chains of glucose stored primarily in the liver and skeletal muscle.
And those hepatic glycogen stores are surprisingly finite. Within the first 24 hours of fasting, the easily accessible sugar in the liver is completely exhausted.
Just 24 hours.
Yes. The liver is actively breaking down glycogen to maintain blood glucose levels for the brain, which relies almost exclusively on glucose under normal conditions. Once that 24-hour window closes, the short-term reserves are gone.
So the body has to manufacture new glucose from non-carbohydrate sources, a process called gluconeogenesis. And this is where the hormonal profile violently shifts.
In a state of surgical stress, you have a massive surge in counter-regulatory hormones, primarily cortisol, glucagon, and epinephrine.
And what happens to insulin?
Simultaneously, the effectiveness of insulin plummets. This creates a state of profound insulin resistance at the peripheral tissue level.
Why would the body make itself insulin resistant?
It does this intentionally. It wants to prevent skeletal muscle from absorbing the limited glucose in the blood, saving it instead for the brain and the acute cellular demands of the surgical wound.
But the brain still needs massive amounts of fuel. As fasting turns into long-term starvation, the liver ramps up ketogenesis, converting mobilized fatty acids into ketone bodies, which the brain can eventually adapt to use.
Right, the brain can use ketones, but here is the critical failure point in the stressed patient. The wound tissue, the proliferating immune cells, and the regenerating tissues are largely obligate glucose consumers.
Meaning they have to have sugar.
They cannot run efficiently on fat or ketones, so the liver is forced to continue gluconeogenesis. And what is the primary substrate for making new glucose when the body is stressed?
The carbon skeletons of amino acids.
Exactly. The hormonal cascade, the high cortisol and glucagon, combined with low functional insulin, acts as a chemical alarm, signaling the aggressive breakdown of skeletal muscle to feed the liver the raw materials it needs to make sugar.
So, if you leave a surgical patient fasted for days, waiting for their bowels to magically wake up, they aren't just resting.
No, they are locked in a hypercatabolic state. They're auto-digesting their own diaphragm and intercostal muscles just to keep their blood sugar high enough to supply the inflammatory response.
The clinical truth here for you listening is that surgical patients aren't just fasting, they're actively starving under immense stress. And that combination rapidly destroys the body from the inside.
Which is why the timing and method of nutritional intervention is arguably as critical as the surgical technique itself.
And that brings us to the fundamental algorithmic starting point for feeding. The golden rule of surgical nutrition. If the gut works, use it.
It's the mantra of every surgical ICU.
If the gut works, use it. It is such an elegant, simple directive, but the physiological rationale behind it is astonishingly complex. Before we decide how to feed, the clinical guidelines emphasize the critical indications for when to step in with artificial nutritional support. We aren't just talking about giving someone a tray of food here. We're talking about prescribing nutrition as a medical therapy.
The threshold for intervention drops significantly in patients facing hypermetabolic states. If a patient is already profoundly malnourished, or if they are battling severe systemic conditions, widespread malignancy, severe sepsis, intracutaneous fistulas, acute necrotizing pancreatitis, major burns, or massive polytrauma, you do not adopt a wait-and-see approach.
You don't wait for them to ask for food.
Yes, exactly. The metabolic fire in these states is raging so intensely that waiting 3 or 4 days for them to resume a normal oral diet guarantees massive, potentially irreversible lean tissue loss. Early nutrition, initiated within 24 to 48 hours, is paramount.
And when the decision to feed is made, the golden rule dictates that we use the gastrointestinal tract enteral nutrition. This usually means passing a nasogastric or a nasogeneral tube directly into the stomach or small intestine and pumping in liquid formulations.
Right.
But why is the gut the vastly superior route compared to just pumping nutrients into a vein? I mean, an IV seems faster.
For decades, the gut was viewed merely as a passive conduit, a pipe that digested food and absorbed the nutrients. But modern gastroenterology reveals that the GI tract is a highly active, massive immunological organ.
It's an immune organ.
Yes. The mucosa of the intestines is lined with a single layer of epithelial cells called enterocytes. These cells are glued tightly together by proteins called tight junctions, forming an impermeable barrier. This barrier separates the trillions of commensal bacteria and endotoxins in the gut lumen from the sterile bloodstream.
And those enterocytes have incredibly high metabolic turnover rates. They need constant fuel.
They do, and their primary fuel source isn't glucose from the bloodstream. It is amino acids, specifically glutamine, drawn directly from the food passing through the intestinal lumen.
So they eat what passes by them.
Exactly. If you starve the gut, if you leave a patient NPO, nil per Os, for days, Those enterocytes begin to atrophy and die off. The tight junctions break down. The mucosal barrier physically degenerates.
And when that barrier fails, you get a phenomenon known as bacterial translocation.
A very dangerous phenomenon.
The bacteria and endotoxins that normally live peacefully in the colon and terminal ileum just slip straight through the degraded intestinal wall, traverse the mesenteric lymph nodes, and pour directly into the systemic circulation.
It causes a massive, self-perpetuating systemic inflammatory response. Sepsis from within.
But by providing enteral nutrition, even at a really low continuous rate, what we call trophic feeds, you are delivering direct metabolic fuel to those enterocytes.
You're keeping the cells plump, maintaining the integrity of the tight junctions, and actively stimulating the gut-associated lymphoid tissue, or GULT, which produces secretory IgA to bind and neutralize luminal pathogens.
This is all encapsulated in a really vital memory hook from the texts. A fed gut is a friendly gut.
I love that phrase.
By using the GI tract, you are literally fortifying the defensive wall. The clinical outcomes reflect this unequivocally. Patients who receive early enteral nutrition have significantly lower rates of infectious complications, reduced instances of severe sepsis, and faster overall recovery trajectories compared to those fed intravenously.
But clinical reality dictates that the golden rule cannot always be followed.
Right. Sometimes the gut is just out of commission.
There are catastrophic scenarios where the gut simply does not work. If a patient has a massive mechanical bowel obstruction, severe ischemic bowel where the tissue is necrotic, high-output intestinal fistulas, or short bowel syndrome where there physically isn't enough absorptive surface area left, well, enteral feeding is contraindicated or physically impossible.
And that is when clinicians are forced to bypass the digestive system entirely and deploy total parenteral nutrition, or TPN. The sources describe this incredibly vividly as the scenario where veins become kitchen pipes.
TPN is a feat of modern pharmacology, really. It is a highly complex, hyperosmolar intravenous admixture. You are synthesizing everything the human body needs to survive into a single bag of liquid.
What's actually in the bag?
It contains a precise ratio of dextrose for carbohydrates, crystalline amino acids for protein, lipid emulsions for essential fatty acids, and a meticulously calculated profile of electrolytes, trace elements, and vitamins.
And because this cocktail is so highly concentrated, particularly the dextrose, you generally can't just run it into a standard IV in the hand or arm, can you?
No, you can't. You can formulate a lower concentration version called peripheral parenteral nutrition, or PPN, for very short-term use. But the osmolarity of full TPN is so high, it would instantly cause phlebitis and destroy small peripheral veins.
How do you get it in?
Standard TPN requires a central venous catheter, a large line placed directly into the superior vena cava right above the heart, where the massive blood flow instantly dilutes the hyperosmolar solution.
But the sources are incredibly explicit about the risks here. TPN is a vital, life-saving bridge, but it is a double-edged sword.
Oh, absolutely.
Because when you feed through the gut, you have natural hepatic buffering. Nutrients go through the portal vein to the liver, which regulates what hits the systemic circulation. With TPN, you are completely overriding millions of years of evolutionary checkpoints and dumping raw nutrients directly into the systemic circulation.
Which introduces massive physiological risk. The primary failure points of TPN can be categorized into three areas. First, providing too little, which fails to arrest the catabolic state and leaves the patient in a state of ongoing deficiency.
And the second?
Second, and frankly far more common and dangerous, is providing too much.
Right, overfeeding. The complications of overfeeding via TPN are severe. Flooding the bloodstream with excess dextrose causes profound hyperglycemia. The tissues simply cannot oxidize that much glucose.
And hyperglycemia is incredibly toxic in the ICU. It paralyzes macrophage function, directly impairing the immune system's ability to phagocytize bacteria. Furthermore, the liver attempts to manage the excess carbohydrate load by converting it into fat, leading to rapid hepatic steatosis, or fatty liver, which can progress to liver dysfunction.
And the third failure point is entirely mechanical, right? It's the delivery system itself, the central line.
Yes. A central venous catheter is a direct superhighway from the outside world into the central circulation. If the hub of that catheter becomes contaminated, bacteria are flushed directly into the heart, leading to central line-associated bloodstream infections, or CLAB-SI. This is immediate, life-threatening sepsis.
Not to mention placing the line.
Right. The physical insertion of the central line carries the risk of a pneumothorax, accidentally puncturing the pleural space and collapsing the lung, or an arterial puncture.
This leads to a really sobering clinical pearl regarding TPN management, particularly in the critically ill. Overfeeding a hypermetabolic septic patient is the ultimate unforced error. The mantra is TPN saves lives, but overconfidence kills.
This brings us back to understanding the cellular reality of the flow phase. When a patient is profoundly septic, their mitochondria, the powerhouses of the cells, are often dysfunctional due to the systemic inflammation. They cannot efficiently process oxidative phosphorylation.
So they can't burn fuel properly.
Right. If you arrogantly look at a massive caloric deficit on paper and decide to aggressively push high rates of TPN to fix it, you overwhelm the broken cellular machinery. The cells cannot burn the glucose.
And instead of creating energy, the metabolism of that excess carbohydrate shifts, resulting in a massive increase in carbon dioxide production.
Which is an absolute disaster for a patient on a ventilator. Their respiratory system now has to work twice as hard to blow off the excess CO2 you just generated by overfeeding them. You inadvertently trap them on the ventilator, increasing their risk for ventilator-associated pneumonia and hastening their respiratory failure. You must respect the metabolic limits of the stressed cell.
And respecting those metabolic limits brings us to arguably the most dangerous, terrifying complication in all of clinical nutrition: refeeding syndrome.
The classic clinical nightmare.
The sources frame this so intensely. You have a patient who has been starving, perhaps severely malnourished prior to admission, or locked in a hypercatabolic state for weeks. You finally secure access, you start feeding them, and the very act of providing life-saving nutrition triggers a catastrophic, potentially lethal chain reaction.
Refeeding syndrome is heavily tested on every surgical board exam because it is incredibly counterintuitive, and if you don't anticipate it, you will kill the patient.
We'll walk us through the mechanism.
To understand it, we have to look closely at the intracellular dynamics of starvation. When a patient has been starved, their total body stores of electrolytes, specifically phosphate, potassium, and magnesium, are profoundly depleted.
But the blood work might look fine, right?
Exactly. The blood levels of these electrolytes might look completely normal on a lab report because the body tightly regulates serum concentrations to keep the heart beating.
Right. The body is desperately pulling the last remaining electrolytes out of the cells and the bones just to keep the blood levels viable. So the patient is a metabolic house of cards. What happens the moment you initiate an aggressive feed, particularly one rich in carbohydrates?
The introduction of glucose into the bloodstream triggers an immediate massive release of insulin from the pancreas. Remember, the body hasn't seen substantial glucose in days or weeks. The insulin spike is violent, and insulin's primary job is to drive glucose from the blood into the intracellular space to be metabolized.
But insulin doesn't just act on glucose. It is a powerful driver of electrolytes as well.
This is the crux of this syndrome. That massive insulin surge forcefully drives potassium, magnesium, and most critically, phosphate out of the bloodstream and rapidly into the cells. Because the total body stores were already severely depleted, this sudden intracellular shift completely empties the vascular compartment. The serum levels crash precipitously.
The resulting derangements are catastrophic. You get profound hypokalemia and hypomagnesemia,
which destabilizes the resting membrane potential of the myocardial cells. The electrical conduction of the heart becomes erratic, leading to lethal ventricular arrhythmias and sudden cardiac arrest.
But the hallmark of refeeding syndrome is severe hypophosphatemia, the sudden vanishing of phosphate from the blood. Why is phosphate the linchpin of this disaster?
Phosphate is the P in ATP adenosine triphosphate, the fundamental energetic currency of every living cell. When serum phosphate levels crash, the cells can no longer synthesize ATP. Without ATP, cellular energy production halts.
So the muscles just stop.
The diaphragm, which requires massive amounts of ATP to constantly contract, simply fails. The patient goes into acute respiratory failure. Furthermore, the red blood cells require phosphate to synthesize 2,3-DPG, a molecule that allows hemoglobin to release oxygen to the tissues.
So the oxygen gets stuck to the blood cells.
Without it, oxygen binds irreversibly to the red blood cells, causing global tissue hypoxia. The patient suffocates at the cellular level, their heart fibrillates, and they die. Not from the starvation, but from the abrupt, unmanaged cure.
It is a devastating cascade, and it entirely dictates the clinical approach to the malnourished patient. The protocols are built around a life-saving mantra. Start low, go slow, monitor electrolytes. You cannot force a starved metabolism back to full speed overnight.
It requires immense clinical patience. If a patient is at high risk for refeeding syndrome, you might start their caloric intake at only 10 to 15 kilocalories per kilogram per day, a fraction of their actual requirement.
And then inch it up.
You advance the rate agonizingly slowly over the course of a week. And crucially, you are drawing blood panels every 6 to 12 hours, aggressively replacing potassium, magnesium, and phosphate intravenously before the insulin shifts can drop them to lethal levels. You must gently coax the metabolic machinery back online.
We have spent a lot of time exploring the profound dangers of the perioperative period, the catabolic storm, the immense loss of nitrogen, the peril of a starving gut, and the razor's edge of artificial feeding. But medical science hasn't just identified these problems, it has built a comprehensive system to combat them. That brings us into the modern era with a philosophy that is radically altering the surgical landscape. ERS, Enhanced Recovery After Surgery.
ERS is arguably the most significant paradigm shift in perioperative care of the last 2 decades. For over a century, the dogma of surgical recovery was largely passive.
The standard protocol was to admit the patient, starve them from midnight the night before surgery, perform the operation, prescribe heavy narcotic painkillers, and enforce strict bed rest with a nasogastric tube in place until the bowels spontaneously demonstrated function days later.
Yes, the traditional thought process was that the body needs absolute rest and an empty stomach to heal. But as we've discussed today, forcing a body into a starved, immobile state during the hypermetabolic flow phase is physiologically disastrous. ERS entirely shatters that passive dogma.
So what is the new philosophy?
The core philosophy of ERS is active metabolic management. It redefines the timeline of recovery. The protocol recognizes that you do not heal by lying motionless in a starved state. You heal by blunting the surgical stress response, maintaining anabolic drive, and reestablishing normal physiological function as rapidly as possible.
Let's break down the specific, actionable pillars of the ERS protocol, starting with the preoperative phase. The first major shift is abandoning the NPO past midnight rule. Instead, ERS protocols actively encourage minimal fasting and specifically utilize preoperative carbohydrate loading.
This directly addresses the short-term starvation mechanisms we explored earlier. Instead of arriving in the operating room with entirely depleted hepatic glycogen stores, already slipping into a state of insulin resistance and catabolism, the patient drinks a complex carbohydrate beverage 2 hours before induction of anesthesia.
So they drink a bunch of carbs right before surgery.
Yes. This ensures the liver is packed with glycogen, insulin sensitivity is maintained, and the body enters the traumatic event in a fed anabolic state. You are actively armoring the metabolism before the scalpel even touches the skin.
The second pillar completely revamps postoperative nutrition, early enteral feeding. No more waiting 4 days for the patient to pass flatus. The modern approach is to challenge the gut immediately.
We circle right back to a fed gut is a friendly gut. The moment the patient is awake and able to swallow safely, they're offered clear liquids and rapidly advance to solid food.
And that prevents the gut wall from breaking down.
By immediately introducing nutrients into the lumen, you stimulate GI motility, preserve the tight junctions of the enterocytes, and drastically reduce the risk of bacterial translocation and subsequent sepsis. The gut wakes up faster when it has a job to do.
The third pillar addresses the physical wasting, early mobilization. We talked about how the body ruthlessly metabolizes skeletal muscle to fuel the immune response. If you leave a patient in bed, you accelerate that atrophy. ERAS mandates getting the patient out of bed, standing and walking, often on the very same day they had a massive abdominal tumor removed.
It seems harsh, but the physiological logic is profound. Mechanical loading, the physical act of muscles bearing weight and contracting, generates local signals that actively resist proteolysis, or protein breakdown. Movement signals the central nervous system that the skeletal muscle is still mechanically required for survival, blunting the catabolic drive to tear it down for amino acids.
And the final foundational pillar involves strict stress control, specifically through multimodal, opioid-sparing analgesia.
This is a critical component of gut recovery. Opioids are notoriously disruptive to the gastrointestinal tract. They bind to mu receptors in the gut, paralyzing motility and causing prolonged postoperative ileus.
So if they don't use opioids, what do they use?
By utilizing epidurals, regional nerve blocks, IV acetaminophen, and NSAIDs, surgeons can provide excellent pain control without paralyzing the bowel. This facilitates the early feeding and early mobilization pillars.
So when you combine a fed, protected gut, preserved muscle mass, and a blunted stress response, the clinical outcomes are spectacular. ERS pathways consistently demonstrate massive reductions in post-op complications, particularly infections and anastomotic leaks. Wound healing is vastly improved.
And a length of hospital stay is often cut in half. Patients are going home days earlier, retaining their functional strength, and returning to their baseline lives with far greater resilience.
It is the ultimate synthesis of all the complex biochemistry and physiology we've explored. ERS proves that active, targeted management of the metabolic environment is just as critical as the surgical technique itself. It takes the abstract concept of the metabolic fire and provides a rigorous, evidence-based blueprint to control it.
And that brings us to the profound central theme that ties this entire deep dive together. When you absorb all this material, you realize that a surgeon does not heal with hands and a scalpel alone. The cutting, the suturing, the reconstruction, that is just the initial mechanical geometry.
True healing, the actual biological fusion of tissue and restoration of function, requires precise nutrition, a deep understanding of cellular metabolism, and impeccable clinical timing.
It empowers everyone involved in the process. It elevates the role of the clinical dietitian and the nursing staff from support roles to primary drivers of survival.
Yeah.
And it empowers the patient. The core message of the source material is that if you arm a patient's biology, if you provide the vital structural cement and meticulously manage the metabolic fire, they will literally fight for themselves from the inside out.
The cellular machinery will do the heavy lifting of recovery.
It reinforces the most inspiring reality of modern surgery. Recovery begins on the operating table.
Recovery begins on the operating table. It's an incredible shift in perspective, and it leaves me with the final, lingering thought for you to consider as we wrap up this deep dive. If optimal nutrition, preserved muscle mass, and fueled biology are the true underlying mechanisms of healing post-surgery, if it is the cellular cement and the metabolic fire that ultimately dictates survival or failure, it profoundly shifts how we should view modern medicine as a whole. Think about how we instinctively view a hospital. We tend to see it like an automotive garage. It's a place where you go to be passively fixed by external tools, where an expert mechanic replaces a faulty valve, stitches a tear, and hands you back a repaired body. But if healing is fundamentally an internal, biologically driven action powered by the substrates you provide the cells, what if we viewed the hospital entirely differently? What if we viewed it not as a mechanic's garage, but as a high-performance athletic facility? A place where your body is actively coached, shielded from extreme stress, and precisely fueled with raw materials so that it can execute its own miraculous evolutionary repairs. If your own biology is the ultimate surgeon, how might that change the way you feed, build, and prepare your body for the inevitable health challenges of the future? It's not just about waiting passively for the scalpel, it's about ensuring you have a massive surplus of cement before the renovation ever begins.